Hello dear friends, today we are going to discuss part of the peripheral nervous system, which is the autonomic nervous system. I know this system might be perplexing many people and it has a lot of details, but if you go a bit by bit you will find that it is very easily to grasp. As you all know, we start from the very beginning. The nervous system is formed of a central nervous system and the peripheral nervous system. And the central nervous system is formed of the brain and the spinal cord. Peripheral nervous system is sensory or motor system. The motor system, the efferent system, is further subdivided into somatic motor system for the skeletal muscles, voluntary control, and the autonomic, regulating the glands, the blood vessels, and internal organs as the intestine, the liver, the spleen, the heart, and so on. And as you all know, the autonomic nervous system is further subdivided into sympathetic and parasympathetic. This is a picture showing the details of the nervous system, and this might be the cause that many people say that it is a very complex system. But if you go a bit by bit, as we said, you will find that it is really simple. So generally speaking, the sympathetic nervous system is present in all the dorsal vertebrae, all the dorsal segments, the thoracic segments, and the upper 2 to 3 lumbar segments. And the parasympathetic, we call the craniosacral system, is present in the fibers of some of the cranial nerves. The nuclei are present in the brainstem, as well as sacral 2, 3, 4 segments. So, sympathetic, dorsolumbar, parasympathetic, craniosacral. Regarding the function, sympathetic is concerned with stress. So when you are stressed by a fight and you are nervous, angry, or you are scared and you want to escape, you are under stress. And the parasympathetic is the domination during peace. So sympathetic, fight or flight, parasympathetic, rest and digest. We are all having a state of homeostasis between the sympathetic and the parasympathetic nervous system, and we are always in a balance between these two types of states, guided by our emotions and our circumstances. Of course, modern time, complex time, the sympathetic dominates. We are almost always under stress. Autonomic nervous system, as we said, is a motor system, but it is an efferent system with 2 order neurons, unlike the somatic nervous system. So all sympathetic or parasympathetic have 2 order neurons, one neuron and the other neuron to reach the effector organ. So we have preganglionic fibers, and we have postganglionic fibers, and we have autonomic ganglion. So if it is a 2 order neuron, meaning a ganglion, pre and postganglionic fibers. And we'll see the difference here between the somatic and the autonomic nervous system. Somatic anterior horn cells going one way to the effector organ, but the autonomic, whether it is for here is the sympathetic, lateral horn cells, ganglion, another order neuron to the effector. The autonomic nervous system, as any part of the motor system, has an upper motor control, and here the upper motor control is present in the hypothalamus. So here you find the hypothalamus sending upper motor control to the parasympathetic nuclei of the cranial nerves and to the sacral segment. Also, it is sending upper motor control to all the thoracic vertebrae and the upper 2 to 3 lumbar segments, all thoracic segments and lumbar segments for the sympathetic. Also the autonomic nervous system, we have ganglion, as we said, whether sympathetic or parasympathetic. This ganglion has a neurotransmitter from one neuron to the other, and it is the acetylcholine. And the neurotransmitter at the target organ is noradrenaline, and for the parasympathetic it is acetylcholine. And the neurotransmitter for the somatic is also acetylcholine. So acetylcholine is the neurotransmitter of all autonomic ganglia, sympathetic and parasympathetic, target organ for the parasympathetic, and the somatic, and some exceptions. You'll see the eccrine sweat glands, although a part of the sympathetic nervous system, yet acetylcholine is secreted at the effector organ or at the sweat glands. The acetylcholine is having two further problems. It has the nicotinic receptors, which is present on all autonomic ganglia, and muscarinic receptors at the target parasympathetic receptors. So we have central acting acetylcholine at the ganglia and peripheral at the parasympathetic. The nicotinic receptors, the acetylcholine receptors at the ganglia are called nicotinic receptors because they were first blocked by nicotine, and at the target organ of the parasympathetic called muscarinic receptors, which is a poison derived from the mushroom because they are blocked by the muscar. So they have nothing to do with the action of nicotine or muscar. And this is to show you again, somatic nervous system, one order neuron, anterior horn cells, one order neuron, acetylcholine, effector organ, which is the skeletal muscle. Sympathetic, we have two order neurons, acetylcholine at the proximal end and noradrenaline or norepinephrine at the distal end, and also the acetylcholine is stimulating the production of adrenaline and noradrenaline from the adrenal medulla, circulating in the blood and producing direct effect on the wall of the blood vessels. And the parasympathetic, as we said, two order neuron, acetylcholine and acetylcholine. Here we have the nicotinic-like action. Here we have muscarinic-like action. So again, two order neurons, the sympathetic, acetylcholine having nicotinic receptors, then the epinephrine is secreted, or noradrenaline is secreted and received at the target by the adrenergic receptors. For the parasympathetic, acetylcholine with nicotinic receptors and noradrenaline distal effector acetylcholine muscarinic receptors. Again, parasympathetic, acetylcholine, nicotinic receptors, second order, acetylcholine, muscarinic receptors. For the sympathetic, first order neuron, preganglionic fibers, acetylcholine, nicotinic receptors also, and the distal is the epinephrine, noradrenaline, adrenergic receptors divided into alpha and beta adrenergic receptors. Here it is norepinephrine or noradrenaline. And exceptions of the neurotransmission, the two order neuron ganglion at the adrenal medulla, although acetylcholine, as we said, at the autonomic ganglia, at the sympathetic ganglia, but acetylcholine at the adrenal medulla stimulates the release of epinephrine, of the adrenaline from the adrenal medulla going to the tissues all over the body. And some say that instead of postganglionic fibers have secreted chromaffin cells, which produce the epinephrine. And another exception, so acetylcholine and producing noradrenaline and adrenaline. Other exception, eccrine common sweat glands, all the sweat glands in the body, part of the sympathetic nervous system, but the target organ at the sweat gland, the neurotransmitter although it is sympathetic, is acetylcholine instead of epinephrine, instead of adrenaline. Sympathetic nervous system, stress, fight or flight, and view of the posterior chest wall vertebral column. On either side of the vertebral column there is the sympathetic chain carrying sympathetic ganglia, and although it is arising from the dorsal and upper two lumbar segments, sympathetic chain extends from the cervical down to the sacrum. So the end of the sympathetic chain is by the ganglion impaired present at the sacrum itself. For each spinal nerve, each autonomic nerve, we have two rami communicantes. A preganglionic fiber, as we said before, the ganglia is white and thickly myelinated, and postganglionic gray and poorly myelinated. And this is the lateral view of the vertebral column, showing the sensory root, motor root carrying the autonomic fibers. The sympathetic fibers leave the motor root and go to the ganglia with the preganglionic fibers. Anastomose and postganglionic fibers join the motor root. So the preganglionic rami also anastomose at the same level of the exit from the foramen, the preganglionic fiber, but go up anastomosing with ganglia above and go down anastomosing with ganglia below, and goes distally anastomosing with distant sympathetic ganglia. So from this we have that it is not that simple. Each preganglionic fiber can anastomose with ganglia in the sympathetic chain at the same level, above the same level, or below the same level of exit. And also some of the preganglionic fibers which are short in the sympathetic system are long, reaching distant ganglia, celiac, superior mesenteric, inferior mesenteric, and so on. So as we said, the anterior for the sympathetic, lateral horn cells, the sympathetic fibers joining the motor nerve and relaying with the ganglia at the same level, ganglia above the same level, and ganglia below the same level before it exits the sympathetic chain. Another motor ventral root and anastomosing at above and below, and then the postganglionic fibers pass to the effector organ. Another nerve joining the motor, and then anastomose. This is the gray rami communicantes, preganglionic, the postganglionic fibers, and the white rami communicantes, which are the white, the preganglionic fibers, and the gray rami are the postganglionic fibers. So here, coming, anastomosing at the ganglia of sympathetic chain, preganglionic, and then the postganglionic join again the motor nerve. Sympathetic postganglionic fibers reach the effect because they are thick, thin myelinated, and they are gray in color. They are not that strong. They join the vessels, so they reach the target organs they work on via the arterial supply. For instance, postganglionic fibers around the aorta, around the common iliac, around the internal iliac, and so on, reaching the target organs. Sympathetic ganglia are inanimate inside the sympathetic chain. However, there are 7 ganglia that have names. In the cervical region, they found 3 ganglia, superior, middle, and inferior cervical ganglia. And there are in the abdomen, distant ganglia in the abdomen, following the arteries. So we have the celiac artery, aortorenal artery, superior mesenteric, inferior mesenteric artery, and the ganglia are present there, so that the postganglionic fibers will reach the target organ. Superior cervical sympathetic ganglion is very important for us, because when you do a cervical surgery, you can injure superior cervical sympathetic ganglion, resulting in what we call the Horner syndrome, because the ganglia is supplying the salivary glands of the face, the lacrimal gland, and the dilator pupillae. So injury will result in meiosis and will result decreased secretion, will result in anhidrosis and some ptosis because the sympathetic nervous system supplies Muller's muscle, elevating the upper eyelid, also through the superior cervical sympathetic ganglion. So injury causes Horner syndrome, ptosis, meiosis, enophthalmos, and anhidrosis. However, the middle and inferior cervical ganglia are involved with the innervation of the heart and receive fibers from upper 4 dorsal ganglia. The heart receives its innervation, middle inferior cervical, and upper 4 to 5 dorsal ganglia. And here we can see, as a general rule, for the sympathetic preganglionic fibers, they are short. Why? Because the sympathetic chain is near the cord. However, we have exceptions where the preganglionic fibers join distant sympathetic ganglia, which is the superior ganglion, celiac ganglion, superior mesenteric, inferior mesenteric ganglion, the celiac, aortorenal, superior mesenteric, inferior mesenteric ganglion. So this is the exception. In the region of the face, as we said, the postganglionic fibers pass from the cervical ganglia to the blood vessels. As we said, they reach the effector organ through the blood vessels, and they pass also through the parasympathetic ganglia but without relay. So every parasympathetic ganglion, the celiac ganglion, submandibular ganglion, otic ganglion, receives parasympathetic with relay, sympathetic fiber without relay, and sensory fibers, of course, without relay. So another peculiar entity for the sympathetic fibers in the face. They follow the blood vessels and they pass in the parasympathetic ganglia without relay. The distant sympathetic ganglia, as we said, they follow the blood vessels. We have the celiac ganglion, so it is supplying all the organs supplied by the celiac artery. For instance, you have the stomach, liver, gallbladder, bile ducts, pancreas, and it arises from dorsal 5 to dorsal 10 segments. These preganglionic fibers are long, anastomosing with the celiac ganglion near the celiac artery and going to these organs with the blood supply. Aortorenal arises from, this is up to T10, here T11, T12, they call, here's the greater splanchnic, the lesser splanchnic nerve, and go, of course, aortic, renal, go to the kidney and ureter. And we have the superior mesenteric ganglion following the superior mesenteric artery, supplying the rising from D12 L1, called the lumbar splanchnic, and supplying the small intestine and the proximal part of the large intestine, and the inferior mesenteric ganglion from L1 L2, what we call the lumbar splanchnic, supply the colon, rectum, urinary bladder, and genital organs. So, celiac ganglion, postganglionic fibers to the arterial supply of the celiac, aortic-renal, kidney and ureter, superior mesenteric ganglion, supply to the blood supply of superior mesenteric artery, inferior mesenteric ganglion, inferior mesenteric artery. Again, you will see it. These are the long preganglionic fibers arising from the sympathetic segments, dorsolumbar, reaching the celiac ganglion, supplying the stomach, liver, gallbladder, pancreas, suprarenal, what we call the greater splanchnic nerve. Then from dorsal, the dorsal, upper dorsal, or dorsal 5 to 10, here dorsal 11 and 12, we get the lesser splanchnic, aortic-renal, and supplying ganglion, supplying the kidney and ureter. And then we have from L1, L2, the greater splanchnic, lesser splanchnic. This is the least splanchnic, and the lumbar splanchnic nerve, which is supplying, relaying in superior mesenteric ganglion and the inferior mesenteric ganglia supplying the intestine. So distally we have the greater splanchnic, lesser splanchnic, least splanchnic, and lumbar splanchnic. The ganglia, celiac ganglion, the aortic-renal ganglion, superior mesenteric ganglion, inferior mesenteric ganglion. Preganglionic sympathetic fibers are inanimate in the chain, except for the nerves going to long preganglionic fibers reaching distant ganglia called the greater splanchnic, lesser splanchnic, least splanchnic, lumbar splanchnic, and sacral splanchnic also, which is the sacral splanchnic nerve. Greater splanchnic, lesser splanchnic, least greater splanchnic, lesser splanchnic, least splanchnic, lumbar splanchnic, and sacral splanchnic nerves. Again, as you see, and the greater splanchnic nerve, as we said, relays in the celiac ganglion. The lesser splanchnic nerve relays in aortic-renal ganglion. The least splanchnic nerve also in the aortic-renal ganglion. And the lumbar splanchnic nerve is divided into upper lumbar, superior mesenteric ganglion, middle lumbar, inferior mesenteric ganglion, and inferior lumbar, inferior mesenteric ganglion. And the inferior mesenteric ganglion, we have the hypogastric plexus, which are the postganglionic fibers supplying rectum, bladder, and prostate. So, not to be lost, the greater splanchnic, celiac, supplies, branches supplied by the celiac artery, as we said. Lesser splanchnic, aortic-renal, going to the kidney and ureter. Least splanchnic, also in aortic-renal. So the lesser and least, aortic-renal, kidney and ureters. Lumbar splanchnic is divided into upper lumbar splanchnic, upper with the superior, the middle with the inferior, and the inferior splanchnic also with the inferior. So the lumbar splanchnic, upper with superior mesenteric, supplying the proximal intestine, supplying the liver, supplying the spleen, supplying small intestine, proximal, large intestine, and middle lumbar splanchnic relaying in the inferior mesenteric, and the inferior lumbar splanchnic also in the inferior mesenteric, from which comes the hypogastric plexus supplying the rectum, bladder, prostate, and genitalia for ejaculation, because the sympathetic is responsible for ejaculation. So, greater splanchnic, celiac ganglion, stomach, liver, spleen, pancreas, suprarenal. Lesser splanchnic, aortic-renal, kidney and ureter. The least splanchnic, also aortic-renal, kidney and ureter. And the lumbar splanchnic, upper lumbar splanchnic, is in the superior mesenteric, the middle splanchnic, and inferior splanchnic in the inferior mesenteric. And the sacral splanchnic forming the hypogastric plexus. There is no inanimate ganglion, without a ganglion, reaching the rectum, bladder, prostate. Functions, sympathetic nervous system, here you don't have to retain because you are stressed. What happens when you are stressed? You get dilatation of the pupil to see more of the visual field. You get inhibition of salivation because there is no time to digest. Saliva has to stop. You get dilatation of the bronchi, increase the air inside so that you can scream, so that you can quarrel with others, and or you can run if you want. And it's not the time for digestion, of course. Inhibition of digestion, liver, get me some glucose to get more energy, so releasing glucose. And at the kidneys, it stimulates the production of adrenaline, noradrenaline in the blood, and it stimulates sweating, and there is no time for micturition during stress, so you get relaxation of the wall and constriction of the sphincter, and there is no time for defecation during stress. You get contraction of the rectum, and you know, for the genital organs, in females it is responsible, sympathetic is responsible for the orgasm, and also for the ejaculation in males, and peripheral vasoconstriction. The opposite, of course, when you are relaxed, as we'll see later on. So, very simple, dilated pupil, diminished salivation, bronchial dilatation. Also there is acceleration of the heart, it's not present here. Tachycardia, inhibition of digestion, glucose production, adrenaline, noradrenaline in blood, sweating, no micturition, contraction of the wall, relaxation of the wall, contraction of the sphincter, no defecation, contraction of the rectum, and it is responsible for orgasm in females and ejaculation in males and peripheral vasoconstriction. So another view during sympathetic, what happens? Dilatation of the pupil, inhibition of the saliva, dilatation of the bronchi, acceleration of the heart, stimulation of adrenaline, noradrenaline, increasing glucose production, inhibiting the intestinal motion of this and the stomach motion, inhibiting urination, and promotes ejaculation and vaginal or uterine contractions during orgasm. Again, and here there is a difference in the heart. The heart has a very peculiar, where the parasympathetic is supplying the SE node and the AV node. The sympathetic supplies the SE node, AV node, and the cardiac muscles directly, increasing the contractility of the heart. So not only we get tachycardia, but increased contractility of the heart, increasing the contraction of the cardiac muscles. Parasympathetic nervous system, the craniosacral system, as we said, some of the cranial nerves, oculomotor, third nerve, the facial, seventh, glossopharyngeal, 9, and the vagus, 10, and also the S2, 3, 4 segments. And as we said, the oculomotor system is present in Edinger-Westphal nucleus, present in the upper midbrain in front of the aqueduct, and the parasympathetic ganglion for the oculomotor is the ciliary ganglion, and the effector is the sphincter pupillary. So during the parasympathetic drive, you will get the constriction of the pupil, and when you get paralysis of the oculomotor nerve, you get dilatation of the pupil, like in conization. Here, Edinger-Westphal nucleus, rostral midbrain, periaqueductal. The autonomic fibers pass through the oculomotor, reaching the ciliary ganglion behind the globe, and reaching the ciliary muscles, and is responsible for the constriction or the contraction of the ciliary muscles and narrowing of the pupil, constriction of the pupil. This is the motor supply to the extraocular muscles. Facial nerve, seventh, nucleus is the superior salivary nucleus in the pons. We discussed this before with the nerves, and the preganglionic fibers are the greater superficial petrosal nerve, a very famous nerve, you know, in Kawasi triangle and Glasscock triangle, in the skull base middle fossa. It is the preganglionic fiber, on the way to the ganglion, and the ganglion is the pteriopalatine ganglion or sphenopalatine ganglion, or The facial nerve also fibers autonomic, parasympathetic for the chorda tympani to the submandibular ganglia. So the ganglia are the pterygopalatine ganglion in the pterygopalatine fossa going to the lacrimal gland and nasal mucosa, and the submandibular ganglion, submandibular, sublingual, salivary glands. So the facial nerve, the parasympathetic part, nucleus superior salivary, preganglionic fibers, greater superficial petrosal nerve and chorda tympani, greater superficial petrosal nerve going to the sphenopalatine ganglion to the lacrimal gland and nasal mucosa, and the chorda tympani, submandibular ganglion, submandibular, sublingual, salivary glands. You'll see this picture. Follow the superior salivary nucleus, and the superior salivary nucleus gives the preganglionic fibers, and the preganglionic fibers, they pass either to the pterygopalatine, anastomosing here, postganglionic fibers pass to the lacrimal gland, or they pass in the chorda tympani and they relay in the submandibular ganglion, supplying the submandibular and sublingual salivary glands. The parasympathetic pathway of the facial nerve, nucleus, two pathways, two ganglia, and effector organs, glands and nasal mucosa, lacrimal gland, nasal mucosa, sublingual, submandibular salivary glands. Of course, chorda tympani supplies taste sensation from the upper anterior 2/3 of the tongue going to the geniculate ganglia. So this is parasympathetic of the facial. Again, superior salivary gland, greater superficial petrosal nerve, chorda tympani, relaying here and giving the postganglionic fibers to the lacrimal gland, and the relay is in the sphenopalatine ganglion, pterygopalatine ganglion, and the pathway is not identified here of the chorda tympani. Glossopharyngeal nerve, ninth cranial nerve, the nucleus, parasympathetic nucleus is the inferior salivary nucleus in the medulla. Superior salivary nucleus was in the pons. Here, inferior salivary nucleus is in the medulla, and we here in the facial we get the greater superficial. Here we have the lesser superficial petrosal nerve. The ganglion is the otic ganglion, and the parotid gland is the effector. So, let's see the glossopharyngeal nerve laying into the otic ganglion and supplying the parotid salivary gland. Ninth, inferior salivary nucleus, ninth cranial nerve, otic ganglion, tympanic plexus, otic ganglion, and parotid. Here again, inferior salivary nucleus, tympanic plexus, going to the otic ganglion, postganglionic fibers near the effector organ supplying the parotid. The vagus nerve, the parasympathetic nucleus, is the dorsal motor nucleus of the vagus. You all know about it, present in the dorsal medulla. When you're working on some of the posterior fossa tumors, you can get just warning from the anesthesiologist saying that the blood pressure is rising, the blood pressure is going down, some irregularities in the cardiac, because you are affecting the dorsal motor nucleus of the vagus, which is present in the vagal triangle. If you remember the floor of the fourth ventricle, the vagal triangle, hypoglossal triangle, the vagal triangle has the dorsal motor nucleus of the vagus, and the preganglionic fibers pass in the vagus proper, and the ganglia are present near the effector organs, and we have short postganglionic fibers. As we said, the parasympathetic, the general rule, very long preganglionic and short postganglionic, because the ganglia near the effector organs, and the vagus nerve supplies carotid, sinus, and body, the heart, lung, bronchial tree, spleen, liver, gallbladder, kidney, stomach, intestine, till the cecum. All these are supplied by so we said carotids, heart and lung, spleen, liver, gallbladder, kidney, stomach, intestine, till the cecum, and what is left is supplied by the transverse, supplied by S, as we'll see, S2, 3, 4. This is the supply of the vagus nerve, giving the lung, the heart, the liver, the spleen, here the carotid, adrenal, stomach, intestine, large intestine, but it gives up to the cecum. Transverse colon, descending colon, and rectum are supplied by S2, 3, 4 segments, not the vagus. So S2, 3, 4 segments are present in the lateral horn cells of these segments. And the preganglionic fibers, it is a parasympathetic preganglionic fiber. It is a long fiber called the pelvic splanchnic nerve, and they join inferior hypogastric plexus. The ganglia are near the effector organs, as we said, and the effectors are the rest of the intestine. The vagus was supplying the cecum, but the transverse colon, descending colon, rectum, and the urinary bladder and the genital system supplied parasympathetic control from S2, 3, 4. So S2, S3, S4, supplying, giving preganglionic fibers long and short postganglionic fibers, and relaying ganglia near the effector organs, and it is called the pelvic splanchnic nerve. So for the sympathetic, we have a series of splanchnic and another one for the parasympathetic, which is the pelvic splanchnic nerve, supplying distal GIT, bladder, and genitalia. The function of the parasympathetic nervous system, as the third nerve produces dilatation of constriction of the pupil. You are resting and digesting. There is no need for the pupil to dilate, and you get through the seventh nerve secretions from the lacrimal gland and salivation, and through the glossopharyngeal nerve salivation. Why salivation? We said rest and digest. So we are going to digest. Saliva helps in digestion, lacrimation to protect and clean your cornea and eye, and the third nerve, dilatation of the pupil, so that you are resting and the pupil, constriction of the pupil, no need to dilate the pupil. And the vagus nerve will slow the heart rate. The trachea and lungs would cause some constriction of the bronchi. We don't need to be dilated. Liver not producing glucose, pancreas reducing its function, and secreting pancreatic enzymes, liver secreting the enzymes to digest. Gallbladder, small intestine, intestinal motions are good so that we can defecate, and urinary bladder, we get, I'm resting, I can go to the toilet anytime, so I get relaxation, contraction of the wall and relaxation of the sphincter. And for the gonads, for males, it is responsible for the erection. So erection is a function of the parasympathetic, ejaculation is a function of the sympathetic, and it goes to the gonads. And as we said, it is a craniosacral system, cranial nerve nuclei, and S2, 3, 4 segments. We'll give you this comparison again about the function of the sympathetic and parasympathetic, and the autonomic control of the heart. As we said, the difference is that both sympathetic and vagus supply the SA node and the AV node, but the sympathetic supplies ventricular myocardium also. Autonomic control of the bladder. The sympathetic produces relaxation of the wall and constriction of the sphincter. Parasympathetic, contraction of the wall and relaxation of the sphincter. And there is somatic control of the external sphincter of the bladder by the pudendal nerves. You will see it with the physiology of micturition. So here, the parasympathetic through the S2, 3, 4, going to the pelvic nerves and reach what we call the pelvic splanchnic nerves, the wall of the bladder and the sphincter, causing contraction of the wall, relaxation of the sphincter. Sympathetic reaching through the hypogastric nerve and causing we have two receptors, beta and alpha receptors, producing relaxation of the wall and constriction of the sphincter, and somatic control of the external sphincter. Again, very simple. S2, S3, S4, pelvic nerve parasympathetic, and dorsal 10 to dorsal to L2, hypogastric nerve sympathetic, and pudendal somatic. Surgical application, we have something called the sympathectomy, sometimes done, used to be done to increase the flow in the blood vessels in cases of Raynaud's disease, Raynaud's phenomenon, vasospasm, but now it's no longer used because it produces only temporary increase in blood flow and then it recurs back again, so it's not very successful. And in cases of hyperhidrosis, profuse sweating of the hands, you do a surgery for the sympathetic chain, you go transaxillary, posterior thoracic or transthoracic endoscopic. And here is, we go to the dorsal 2, dorsal 3, and we do here an endoscopic posterior approach. This is the hyperhidrosis. And we cut between, in the sympathetic chain, between dorsal 1 and dorsal 2. So you have a sympathetic chain, you cut this chain, and this will reduce the sweating, but it is only temporary. Clipping and microcutting. This is the sympathetic chain, transthoracic endoscopic view. And there are also tumors of the sympathetic nervous system. The most important is neuroblastoma in children, arises from the adrenal medulla between the age of 2 to 6 years. It sends distant metastases, so you can find metastases in a child between 2 and 6. We should first think about neuroblastoma, and usually sends to the skull and near the orbit and treated by surgery and chemotherapy. And also neuroblastoma can arise from the sympathetic chain and through the rami communicantes can pass into the spinal cord, causing paraparesis, also treated by excision and chemotherapy. And there is a benign tumor of the sympathetic chain, ganglioneuroma, and intermediate, what we call the ganglioneuroblastoma. So these are the tumors, sympathetic chain. Commonest is the malignant one, neuroblastoma of the chain and the medulla. And ganglioneuroma is a benign tumor of the chain. Ganglioneuroblastoma is an intermediate grade tumor. And this is to show you an axial view where the neuroblastoma of the sympathetic chain entered through the foramen and reached inside the canal. So you spend several hours getting this part, dissecting it from the cord, and the general surgeon gets the retroperitoneal in 1 second. But this is the complaint. The main complaint is paraparesis. So you get a very small piece. He gets 100 times the size of your piece in 2 minutes. Yes, that's life. And some metastases from the neuroblastoma of the adrenal can reach the petroclivar region, can reach the skull, can reach cerebral pontine angle, can reach the lumbar region. And one of the favorite sites is the skull and orbit, as we said, causing proptosis. So you have a proptosis in a child between the age of 2 to 6 years. Do him an abdominal sonar. If you find the mass, it is a neuroblastoma. And this is the child. Of course, There is differential diagnosis, Wilms tumor also in children, but I'm talking about the neuroblastoma having tendency to reach the skull for metastasis and usually near the orbit, and you get this picture, immediately do an abdominal sonar. Thank you very much for your attention. I know that this was a tough system, but if you hear it 1 or 2 times more, you will find that everything is settled and easy, and we hope we meet again with one of the interesting topics in our journey in applied neuroanatomy. Thank you very much for your attention, and goodbye.